right, we're continuing to talk about renal failure. Y'all be ready to be rid of this? I do too. I like renal. Makes sense, doesn't it? Okay, we don't have many more slides to go. So, nursing management. Of course, you know, how many times have I said complete history and physical? How important that is? Do you need to look back and see? So if I give you a situation and I tell you that 2 weeks ago the patient experienced a GI bleed and they've come in with decreased urinary output, is your brain going to start thinking acute kidney injury? I know we're talking about chronic disease, but anyway, how important that history and physical is. Assess current and past use of prescription and over-the-counter medicines. Very important, especially what? Herbal preparations. Why do we need to be concerned about herbal preparations? They're not FDA regulated. What else? Do you know the concentration that you're getting of any of those herbs? No. So sometimes they can be very potent. Sometimes they can not be potent enough, okay? What are their dietary habits? What could contribute to acute kidney injury or renal failure? If I have a consistent diet of high what? High sodium, high protein. Okay, so y'all are eating all these bags of potato chips and drinking these sodas. Overloading your kidneys. It's okay. I know you have to have salt and sweet, so it's okay. Assess their support system. What do I mean by that? Family. Do they have family? Okay. Encourage them to what? So if they don't have family support, might they not keep their follow-up appointments? Sometimes we need somebody to just stay on us, don't we? But sometimes that's my job. Sometimes this faculty gets involved in your life, okay? We care about you. I will tell you that this is probably the only nursing program in the state of South Carolina, or possibly in the country, where this faculty takes a personal interest in you, and your success is our business as well. And that we care that you are successful and do it in a very excellent way, because you're going to be taking care of us one day. Don't make us have to get up off the stretcher, okay? Something that's very, very important that's next is drug therapy. And this is on page 1112, 1175. And it talks about drug therapy for hyperkalemia. It talks about all those different strategies. And you know that on table 47.5, the therapies for elevated potassium is going to be on your test. Okay, it says every effort is made to control hyperkalemia with restriction of high-protein foods and drugs. Acute hyperkalemia may require treatment with IV glucose and insulin or IV 10% calcium gluconate. Sodium polystyrene sulfonate, a cation exchange resin, is commonly used to lower potassium levels in stage 4 and can be administered on an outpatient basis. So remember that. Make sure you go back over that table. Tell the patient to expect some diarrhea, because the K-oxalate acts as an osmotic laxative agent, and so sometimes your patient may what? What else are y'all giving for that's oral, that's orange-looking liquid for patients to prevent constipation, get them to have a bowel movement? Comes in a little plastic cup. What? Yes, a laxative what? No, Colace is a little red tablet. I'm drawing a total blank on it, or I would tell you what it is, because what no, it's not Miralax. What, Erica? No, not Metamucil. We give this to your liver patients. Lactulose. Okay, thank you. I don't know why my brain couldn't think that, okay? And so a lot of times the patients, when you're giving them that, even if they're not a liver patient, but you may be giving it to prevent constipation, they may refuse it, because what does it do? Causes them to go poop. It's supposed to cause them to have several soft bowel movements, okay? So we are going to give the K-oxalate, and it's very important. Now, the next sentence says, never give sodium polystyrene sulfonate to a patient with a hypoactive bowel or a paralytic ileus. So you have to listen to what first? Very good. The last sentence says, if changes appear in the ECG, such as peak T waves, wide QRS, dialysis may be required to remove excess potassium. Right? Did I tell you that? Okay, so if they have hyperkalemia with ECG changes, must be immediately dialyzed. Makes sense? We got to save their life. We don't want to do CPR. Hypertension talks about all those. Well, it talks about a DASH diet. The last sentence on 1113 or 1176, it says most patients require 2 or more drugs to reach target blood pressure. Antihypertensive drugs most commonly used are diuretics, calcium channel blockers, ACE inhibitors, angiotensin receptor blocker agents. Okay. The last sentence in that section above CKD, MBD, it says blood pressure control is essential to slow atherosclerotic changes that could further impair kidney function. Everybody with me? Okay. Interventions for chronic kidney disease, mineral bone disorder includes limiting dietary phosphorus. Where's phosphorus? Do you need to be reading labels? Administering phosphate binders, supplementing vitamin D, and controlling hyperparathyroidism. So on the top of 1113, 1176, it says phosphate binders include, everybody with me? Calcium-based binders, calcium acetate or Foslo. Anybody give some of that? Okay, good, Erica. Calcium carbonate, Caltrate. They bind phosphate in the bowel. You need to know what these drugs do, and then excreted, bless you, in the stool. The last sentence in that paragraph says non-calcium-based phosphate binders such as lanthanum carbonate or Fosrenol and sevlamir carbonate or Renvela or Renagel. Anybody give any of that? Okay, same kind of thing. To be most effective, administer phosphate binders with each meal. Constipation is a frequent side effect. Next paragraph. Because bone disease osteomalacia is associated with excessive aluminum, aluminum preparation should be used with caution in patients in kidney failure. Do not use what? Magnesium-containing antacids such as Maalox malanta, because magnesium depends on the kidneys for excretion, and your patient is in a state of what? Hypermagnesemia. Next paragraph, hypocalcemia, problem in later stages. Inability of GI tract to absorb calcium because of vitamin D. So supplemental calcium and vitamin D should be given. Next paragraph, treatment of secondary hyperparathyroidism and end-stage kidney disease. Patients require activated form of vitamin D because the kidneys no longer possess the ability to activate vitamin D. You're going to need to go back over all of this, okay? This is just a quick down and dirty. Active vitamin D is available as oral or IV calcitrol or rocaltrol, Calcigex, IV pericalcitrol or Zemplar. Anybody give that drug? PO? Or oral or IV doxorcalciferol or Hectrol, and can reduce the elevated levels of parathyroid hormone. 2 paragraphs down. Cinacalcid or Sensipar, a calcimimetic agent, is used to control secondary hyperparathyroidism. Calcimimetics mimic calcium and increase the sensitivity of calcium receptors in the parathyroid glands. As a result, parathyroid glands detect calcium at lower levels and decrease parathyroid secretion. So all those are excellent drugs. You must know them for your test. Anemia, what I tell you we're going to give them? Okay, good. On 1114, 1177, third paragraph down, it in the second paragraph it says, if EPO is used in the management of anemia, recognize that uncontrolled hypertension is a contraindication and that EPO may exacerbate hypertension. So you have to be careful. Next paragraph, another side effect of EPO therapy is the development of iron deficiency from increased demand for iron to support erythropoiesis. Iron supplementation is recommended if plasma ferritin concentrations fall below 100. You don't need to know that. So support the use of parenteral iron with a much higher ferritin value in order to optimize treatment. Most CKD patients receive iron supplementation either by mouth or parenterally. Okay. Oral, and down a couple sentences, orally administered iron should not be taken at the same time as phosphate binders. Important for you to remember, because calcium binds the iron, preventing its absorption. Next paragraph, most patients receiving hemodialysis, where it says HD, are prescribed iron sucrose IV, Venafir or sodium ferric gluconate in sucrose injection or Felicet. Supplemental folic acid, yes. Okay, blood transfusion should be avoided in a treating anemia. At what point are we going to give you a blood transfusion when your hemoglobin's where? Yeah, below 6. That's not good. Walking around with a 6 hemoglobin? Okay, dyslipidemia, we're going to give them what? Statins. On the right-hand side, it says complications of drug therapy. Why do we need to be concerned about drug therapy and complications? Because your kidneys can't break it down and can't excrete it. Okay, so the last sentence under that says drugs of particular concern include digoxin. Why? What does digoxin do inside your body? It causes what? Increases the strength of contraction and decreases your heart rate. So you have to check what before you give this digoxin? Patient's apical pulse. And it should be what? Above 60 or 60 or above. Diabetic agents such as metformin, glyburide, those are what? Oral anti-diabetic agents. Antibiotics such as vancomycin, gentamicin, and opioid medications. Questions? Very important stuff under these drugs on your test. Okay, health promotion continued. So early identification of patients at risk. We already talked about that. Interventions to maintain and prevent or delay progression. And when conservative therapy is no longer working, the patient has to undergo hemodialysis, peritoneal dialysis, and on a transplant list if available. Okay, on 1116 or 1179, table 4712, it talks about patient and caregiver teaching guide. It says one, necessary dietary and fluid restrictions. So dietary restrictions: protein, sodium, potassium, phosphorus. Difficulties in modifying diet and fluid intake. Signs and symptoms of electrolyte imbalance, especially high potassium. So this is a teaching guide. Alternate ways of reducing thirst, such as sucking on ice cubes, lemon, or hard candy. A popsicle? Rationales for prescribed drugs and common side effects. Examples: phosphate binders include calcium supplements used as phosphate binders should be taken with meals. Calcium supplements prescribed to treat hypocalcemia directly should be taken on an empty stomach, not at the same time as iron supplements. Make sense? Remember that. Iron supplements should be taken between meals. What does the iron supplement cause? Constipation. Number 6, very important. The importance of reporting any of the following: a weight gain of greater than 4 pounds, which is 2 kilograms. How much fluid is that patient retaining? Okay. Increased blood pressure, shortness of breath, edema, increasing fatigue or weakness, confusion or lethargy. What's one of the first signs of congestive heart failure? That's your number 1 answer. And number 7, need for support and encouragement, share concerns about lifestyle changes, living with a chronic illness, and decisions about the type of dialysis or transplantation. Is this patient going to go through a period of depression, trying to make those decisions and thinking, oh my gosh, you're looking at what? Your mortality? Okay. Any questions about this so far? Okay. Next thing we're going to talk about is treatment for all this, and so it's dialysis, and it starts on page 1117 or 1181. It's initiated when uremia is unable to be managed conservatively, when the GFR is less than 15 milliliters per minute, or what else have I told you that we would need to dialyze the patient immediately for? Hyperkalemia. Okay, alterations in your blood glucose levels. What else? A seizure. What else? Hypertension. Good. We'll just say electrolyte imbalances. Okay. Encephalopathy. Big word. Encephalopathy. Altered level of consciousness. Yes. Caused by 2 things. Could be ammonia and magnesium. Okay, good. Pericarditis. If I have pericarditis, need to get me dialyzed, okay? All right. This is hemodialysis. It says dialysis is used in acute kidney injury or acute renal failure, or to maintain life in patients with chronic kidney disease until transplant is available. How long can you stay on dialysis? Anybody know how long somebody's been on dialysis? Jonelle? 17 years. How many different dialysis access sites did he have? Do you know? More than one? Okay, wow. So the way that dialysis works is it's movement of fluid and molecules across a semi-permeable membrane from one compartment to another. Substances move from the blood through the semi-permeable membrane into a dialysis solution referred to as dialysate. Important for you to note. This is hemodialysis we're talking about. This is in your book on 1117 or whatever the other page was I gave you, 1182. Okay, dialysis becomes the artificial kidney. Have y'all seen a dialysis machine? Everybody seen one? Okay. So we have to correct fluid and electrolyte imbalances and remove waste products from this patient or they become toxic and die. Yes? Two methods, peritoneal dialysis and hemodialysis. In peritoneal dialysis, the peritoneal lining, where is that? Inside your abdomen, acts as a semi-permeable membrane. It's accessed through a catheter inserted into the peritoneal cavity. And if you look at figure 47-6 on page 118, 1182, 3 or 4, somewhere in there, at figure 47.5 and 47.6, that shows you the peritoneal catheter there. Okay. Used to be that you had to wait 7 to 14 days before you could use the peritoneal catheter. So now it's not that critical, and they can use it pretty much immediately. So how do I care for this? Do I need to clean it good? Okay, it's not sterile. This is your skin. But does the skin need to be inspected daily, and I need to cleanse with soap and water and make sure I rinse well, that it's dry? Okay, good. So daily catheter care, and what need to inspect for what? Signs and symptoms of infection. So clean and dry. Dialysis solutions are going to be prescribed by the physician, okay? Depending on certain factors. Now, there are 3 phases. Your book talks about these phases. On page 1118, 1183 on the right-hand side, it says dialysis solutions and cycles. So the 3 phases of peritoneal dialysis cycles are inflow or fill, dwell or equilibration, and then drain. They're called an exchange. So during inflow, a prescribed amount of solution, usually 2 liters, is infused through an established catheter over about 10 minutes. If the patient is experiencing discomfort, can you slow it down? Yes. The flow rate may be decreased, of course, if the patient has pain. Next cycle is a dwell phase or equilibration, where diffusion and osmosis occur between the patient's blood and the peritoneal cavity. The duration lasts from anywhere from 20 to 30 minutes to 8 or more hours, depending on the method used. Then drain time should take 15 to 30 minutes and may be facilitated by gently massaging or changing positions. Cycle starts again with the infusion of another 2 liters of solution. For manual peritoneal dialysis, a period of about 30 to 50 minutes is required to complete an exchange. In the last paragraph, it says, next to last, ultrafiltration. Everybody with me? Fluid remove during peritoneal dialysis depends on osmotic forces, with glucose being the most effective osmotic agent currently available. So glucose is in that dialysate that pulls everything in. Dextrose remains the most commonly used osmotic agent in peritoneal dialysis solution, relatively safe and inexpensive, but has been associated with high rates of peritoneal glucose absorption, leading to problems with hypertriglyceridemia, hyperglycemia, and long-term peritoneal membrane dysfunction. So on 1119, 1184, it talks about the different peritoneal dialysis systems. It talks about an automated peritoneal dialysis, continuous ambulatory peritoneal dialysis, which is good. This allows the patient to be up and moving around. Also, it allows the patient to have those exchanges occurring at night while they're sleeping. So is that good? Okay, peritoneal dialysis is less traumatic on your patient because it's slower and it causes the fluid not to be removed as quickly as hemodialysis. Okay, it doesn't cause the quick shifts like hemodialysis does. Okay, a history of multiple abdominal surgeries or severe pathological conditions is contraindicated. So if your patient has severe diverticulitis or has ascites and has had multiple paracentesis, also if your patient has experienced pancreatitis, they are not a candidate for peritoneal dialysis, bless you. So any abdominal adhesions, why would you have an abdominal adhesion? What causes those? Trauma, surgery, okay, you have an increased risk of adhesions. If you're excessively obese or have infections, pre-existing vertebral disease, chronic back pain, you're not a candidate for peritoneal dialysis. Because I put 2 liters of fluid in your belly and you're walking around with that, could that cause a problem? Okay. Severe COPD. Why am I concerned about that? What's in your abdomen? All that fluid. Is it going to impinge on your diaphragm and your diaphragmatic excursion and your ability to fill your lungs full of air and breathe? That will predispose you to what possibly? Pneumonia, atelectasis, fluid buildup in the lungs. Very good. Death? Okay. Advanced peripheral vascular disease are also contraindications for peritoneal dialysis. These are absolute contraindications. Questions about that? Okay. Complications of peritoneal dialysis. Make sure you know this. This is in your book on 1119, 1184. May be a good select all that apply. Exit site infection. So what do I need to do every day? Check the site. Keep it clean and dry. Peritonitis. What is peritonitis? Okay, inflammation and infection of the peritoneal cavity. We're going to talk about that a little more in just a second. Abdominal pain, outflow problems, hernias. Oh, hernias. So those are complications of peritoneal dialysis. Lower back problems, you can understand that. Bleeding associated with peritonitis, not bleeding out, but some bloody effluent or discharge from the drain fluid solution. Pulmonary complications, that makes sense to you, right? Okay. Protein loss, they lose more protein with peritoneal dialysis, so what am I going to be able to have in my diet? More protein, okay? But again, in any patient who has kidney compromise, the amount of protein must be monitored because we don't want to cause them to have further elevations of any of those electrolytes. Carbohydrate and lipid abnormalities. These may develop. And of course, if we have elevated lipid levels, what does that potentiate that can cause us to have major problems? Atherosclerotic changes. Very good. And cardiac disorders. Okay. So you have a handout that I've given you that's on complications of peritoneal dialysis. Yes? So it says the first complication is peritonitis, and what I'm looking at is a cloudy dialysate, or when the outflow, when the dialysate comes out after it's completed the exchange, it's going to look cloudy. It needs to be cultured. If the patient complains of abdominal pain or abdominal distension, tenderness, I need to check it for leukocytes. I need to dipstick it for leukocyte esterase. Okay. If the patient has an elevated temperature, a fever, and if the patient develops constipation, diarrhea, or nausea and vomiting, those are all significant. So causes most often, oh, hello, what's over there? Staphylococcus aureus, where is that? Everywhere, it's all over your bodies. Fungal infections, gram-negative rods, now those would be the bad ones that could lead to what? Septicemia, and you can die? Yes. Pain during inflow, too rapid rate of infusion, too large a volume, During outflow, at the end of emptying, maybe the omentum entering the catheter at the end of outflow. What's the omentum? Is it in your abdomen? What is it? It's a fatty layer that covers your intestines? Okay. Leakage, fluid around the catheter, edema of the penis or scrotum. Okay, is your male going to be very happy with that? No. Overfilling of the abdomen, the catheter may have migrated. Respiratory problems, we talked about this, shortness of breath, decreased breath sounds, inadequate chest expansion, causes, again, abdominal fullness that compromises diaphragmatic movement, maybe a hole in the diaphragm. That would not be good if there's dialysate leaking up in there, would there? Okay. Questions about that? Let me see what's on in your book. Peritonitis, again, on 1119. 1183 talks about peritonitis, hernias, lower back problems, bleeding. Again, bloody effluent. Pulmonary complications, protein loss. It talks about that. Okay. Any questions about peritoneal dialysis? Okay, the next is hemodialysis. 1943 was the first time that hemodialysis was performed on a patient. 1943. That wasn't very long ago, was it? I mean, I know it seems like a long time ago to some of you, but it really wasn't that long ago. Okay, so we've just still been doing this kind of new. The artificial membrane is a semi-permeable membrane, again, filters the blood. Immediate dialysis, again, I'm saying this again, if what? If the patient has pulmonary edema or congestive heart failure. I didn't mention that before. Well, I did mention that before, but I didn't mention that the last time we talked about it. Uncontrolled hyperkalemia. Hyperkalemia or other life-threatening sequela. So hypervolemia, hypertension, pericarditis. We just talked about all those. Sorry. Okay. Hemodialysis involves removing unfiltered blood from the patient, filtering out the waste products, and returning the filtered blood back to the patient. Must have vascular access to accomplish this. So, we have to have either an internal AV fistula or graft. It says that the AV fistula is a surgical anastomosis of an artery and a vein. If you look at figure 47.8 on the bottom of page 1120 and 1185, it shows you pictures of that, where they've anastomosed, showing you the vascular access. A is an AV fistula, and B is an AV graft. So there's an external plastic component that's connected to that artery and vein. So I have to have venous access and arterial access going on here. Do I need to know the type of access device that my patient has and how to access it appropriately if I'm a hemodialysis nurse? Okay, good. It says it's not available for immediate use, that it must mature. However, Dr. Ross is putting in those big box-like things that they can use immediately to dialyze the patient. Okay? How many of you have taken care of a patient who is on dialysis? Did you access that? Did you assess their access area? Okay, good. So you have to assess the patency of the fistula before each session. You auscultate for and palpate for on your test. Okay? So make sure you know that. Now, what else is very important about this access site? What must you do, nurse? You must be vigilant about it. The patient must be vigilant about it. What? Robert, what? No blood pressures in that arm. You have to protect that arm, right? What else shouldn't happen in that arm? No blood draws, okay? No blood draws from this patient. No sticks in this arm. So this patient needs to protect this arm because it's their lifeline, right? Okay, very good. Should there be a sign on the door and above the head of the bed? Okay. Should it go down to any laboratory diagnostic procedures with the patient? Somebody needs to know that, don't they? I don't know. Maybe we need to put it on their chest, tape it to them or something. Okay. The AV graft is synthetic or vessel implant anastomosed to between an artery and a vein, cannulated with a large bore needle. What size needle do they use? What, Josh? 18 or greater? 18? 8. An 8. Dialysis needles are 8. How big is that? Big as your finger? It's what? Okay, I remember starting a 16, and that was like a 10-penny nail to me. But yeah, big. Got to get the blood out and get it back in the patient. How long does the patient undergo hemodialysis? How long does it take? 3 to 4 hours. Okay, is that a long time? When I think about my husband, who's a golfer, I usually give him 5 hours to play golf. And I think about if you're a dialysis patient, here you are sitting in this dialysis clinic undergoing that for half of your daylight hours. Okay. What time do they start dialysis in the morning? What, 3 a.m.? So if you're a dialysis nurse, if you work your 8 hours, you're done by noon? That's not so bad, is it? Then you have the rest of the day to play. Okay. Okay, now one of the bad things about this when we used to use this AV graft is that it had a high risk for thrombosis. What does that mean? For clotting, okay? And so it could come apart and your patient could hemorrhage? Yeah, so we don't use these anymore, okay? So let's see, where are we? These are some sites where those grafts may be used. I don't think I want one in my ankle area, do you? Okay, so the subclavian, this is going to be most often a temporary device that we're going to use. And the femoral vein, those, hate them there. Hate them there. Why? Yeah, high risk for infection, and what else? I mean, can you keep the patient clean? And most often it's what size patient that gets this? A very obese patient. And they got so many creases down there. If they have urinary incontinence, then is urine all over that? I just hate it when doctors put them there. I'd much rather them be in the subclavian. Okay, they need to be at least a double, if not a triple lumen catheter that's going into that patient, correct? Okay. Complications associated with a fistula and an AV graft. These are also identified for you on page 1122, 1186. Okay? All right. It says thrombosis, and we talked about that. So you always do what before you access it? Palpate for and auscultate for okay. Thrombosis, hemorrhage. Hemorrhage. Your patient can hemorrhage. Why? What is in that the dialysate that all my blood is coming out of my body and going through this dialysis machine? What has to be in there? Heparin. Heparin has to be in there because why? We want the blood to clot in there. We want the patient to get all the blood back that they can. Yes, okay. Infection, big one. Aneurysms, swelling, ischemia of the hand. So you always protect the graft site and the extremity, always. No blood pressures, no sticks in that. Let's see what I want to tell you. Hypotension is not listed here, is it? Okay, 1122, 1186 at the bottom, it says complications of hemodialysis, hypotension. It occurs during hemodialysis primarily resulting from rapid removal of vascular volume causing hypovolemia, decreased cardiac output, and decreased systemic vascular resistance. The drop in blood pressure may precipitate a feeling of lightheadedness, nausea and vomiting, seizures, vision changes, and chest pain from cardiac ischemia. So do you think that they might be coding patients over there in the dialysis clinics? Sometimes they may, okay? Muscle cramps can be associated with that as well. Loss of blood, again, bleeding after the removal of the needles, if they've received too much heparin or have clotting problems. Hepatitis, most often hepatitis C. How does this patient get hepatitis C? How do you think? What, Crystal? Blood transfusion? Okay, but they get hepatitis C from the dialysis. So something's not going on right with the machines, maybe? Okay. So need to be cleaned appropriately, correct? Okay. Effectiveness of hemodialysis on 1123. 1187, it says hemodialysis is still an imperfect therapy. Couple sentences down, it says, however, it does not alter the accelerated rate of development of cardiovascular disease and the related high mortality rate. So it's a good thing because of that. Yearly death of patients receiving maintenance dialysis remains high at an estimated 19 to 24%. Majority are caused by cardiovascular disease, stroke, or MI. Infectious complications are the second leading cause of death. Okay, so before each hemodialysis session, I must assess the following. I have to weigh the patient and take their vital signs. I need to assess them for peripheral edema. I need to listen to their heart and their lungs. And also assess the patency of the access device. And assess the general condition of their skin. So the difference between their previous post-dialysis weight and their present pre-dialysis weight determines the amount of weight to be removed. This is the amount of volume that I'm going to be removing. Does everybody equate weight and volume? Okay. So no more than 1 to 1.5 kilograms should be gained between sessions. So why would I be gaining more fluid between sessions? So that's a day in between, right? So every 3 days you have dialysis? So why would I be gaining excess fluid? Not following my diet. I just ate that bag of potato chips or that whole bag of popcorn that Felicia had. Okay. So, but we want to avoid hypotension in these patients. Vital signs are every 30 to 60 minutes while they're on dialysis. And again, it's either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So complications, again, hypotension, muscle cramps, blood loss, post-dialysis from the access site. So it's going to be a pressure dressing on that access site. Okay. Hepatitis B and C. Most often it's C, though. And the patient can develop sepsis. Okay. On 1128, 1193, table 4715. Again, these are complications of dialysis and transplantation. So they're comparing peritoneal dialysis and hemodialysis. This looks like a good select all that apply kind of question. Just stated to you in a little different manner. Chronic renal, continuous renal replacement therapy. Pretty much this is going to be your patient in ICU, in the unit, the inpatient dialysis unit, or in critical care with a nephrology nurse providing that. Transplantation, do we have enough kidneys to go around? Okay. Who gets kidneys and who gets livers and who gets transplants? Well, hopefully the sickest people. Some people who are famous have received more than one organ, haven't they? I think about, so somebody else had to die for you to get that second organ because you continued to drink alcohol if it was a liver? So before you get a kidney transplant, what are some things that they need to question you about to make sure that you're a candidate, a good candidate to receive that kidney? Your lifestyle, like what? Give me some examples. Is smoking a risk factor for kidney disease? Kidney cancer and bladder cancer. Okay. What else? Drugs. Okay. Compliance is important. Okay. So I'm going to tell you that I think I told you before that if you're a diabetic patient, you are going to develop the complications. Is renal failure a complication associated with diabetes? Okay. So the poorer the lifestyle that you lead, the quicker you're going to experience the complications. Does that make sense to you? Everyone's going to experience those complications, but the patient who maintains that stringent blood glucose level is going to postpone those complications till later versus someone who just doesn't care. Just, I'm going to live my life. And that's just how it is. And who is mostly at risk for that? Younger people, adolescents especially. Okay. So kidneys transplants have been very successful. Again, what do I need to know about matching you up for a kidney? Your blood type, okay. Your HLAs, okay. Who's the best donor for a kidney? A live donor. Your identical twin, okay. It might be a parent that would be a good donor for you, and sometimes there's a cadaver donor. But again, remember I told you that if you're going to undergo transplantation and it's a donor kidney, the surgeon has the last call on whether or not the kidney was maintained appropriately and whether or not they're going to actually transplant it inside the patient. Yes? Okay. And if we do a transplantation, the patient is going to be on immunosuppressive therapy as well. So the last couple of things, and transplant is talked about on page 1124 and 1193. Talks about the histocompatibility studies. Probably one question on your test about this. Figure 4715 on 1126, which is 1190 something, shows you where that new kidney is going to go, and shows you how it's connected to the bladder. And then on 1127, 1193, it talks about immunosuppressive therapy and complications of transplantation. So I need for you to go over that. And rejection is a biggie, okay? It can be hyperacute, acute, or chronic rejection that goes on in this patient. Of course, infection from the surgery itself, cardiovascular disease, malignancies. And again, on that same page where 4715 is, it talks about some of those complications, okay? Now, it says corticosteroid-related complications. Does anybody know what can happen if you're on high doses of corticosteroids for long periods of time? What? Okay, Cushing's, yeah. What's not a good thing that can happen? I know Ms. Goff talked about it. What? Yes, it lowers your immune response, but what else? Acellular necrosis of the head of the femur? Okay, so that means that I have like a sterile fracture. So I have a fracture and I fall. Yes, because there was necrosis of the head of the femur that happens with high steroid use. Okay. Okay, and the last slide I think is out there on there for y'all. Okay, it talks about rejection. So signs and symptoms of rejection. Sorry, lights out a minute. Okay, it talks about hyperacute up here. It says the onset is within 48 hours after surgery. Important for you to note. So if I give you examples of this patient had a kidney transplant 48 hours ago, they're experiencing elevated temperature, elevated blood pressure, and pain and tenderness over the transplant site. Where's the transplant site? Where's that new kidney? In the iliac crest. Treatment is immediate removal of the transplanted kidney, and the patient goes back on dialysis. So acute rejection occurs 1 to 2 years, 1 week to 2 years post-op. Most common in the first 2 weeks. Oliguria, anuria, is that an indication my kidney is failing? Elevated temp, elevated blood pressure, flank tenderness. This says over the transplanted kidney again. Lethargy, low specific gravity. What is it? You're going to get that right on your test? Okay. Fluid retention, weight gain, elevated BUN, serum creatinine. Treatment, increase the doses of the immunosuppressive drugs. Okay, if it's just an acute reaction. If it's chronic, can be gradual over months to years, gradual increase in BUN and serum creatinine. How closely am I going to be following this patient? I hope pretty close. Imbalances in electrolytes, fatigue, proteinuria, hypertension. It may be irreversible, but most often it is not. So then they go back on a transplant list and back on dialysis. Questions? hyperacute. Okay? All right, yay, we're done with renal failure. So go take a break and come back at 10 after, and we'll start infectious disorders. I know you're tired, but we got to get on with this.